Hello there. My name's Dan Monnery. I'm a palliative care consultant at the Clatterbridge Cancer Centre in Liverpool, and I'm also the chair of the National Steering Group on Enhanced Supportive Care within the UK Association for Supportive Care in Cancer. And I have been invited to talk to you briefly about demystifying death and palliative care. So the Make Seconds Count team tells me that by the time you'll watch this, it will be Demystifying Death Week, which I've never heard of. But it sounds like that week has got quite a lot of heavy lifting to do, if you ask me. Anyway, my part of it is going to be to talk about palliative care and what that means. So they've given me some questions to answer and see if I can demystify some of it for you. So the questions that I'm going to address are: what exactly is palliative care? When should people access it? And what are the different options? So quite straightforward stuff. Hopefully it'll be informative. It's going to be fairly light-hearted, so don't worry, but we'll work our way through it. So, first of all, what is palliative care? Well, this is the WHO, the World Health Organization definition. I don't know if any of you were at the Make Seconds Count conference last year where I came to speak, and this was the definition I gave you then. I'm not going to read through it, but essentially what it's about patients when they have life-threatening illness and their families, and providing symptom support, psychological support, psychosocial support, and spiritual support for those people, regardless of all of the other treatments those people are receiving. So fairly well rounded, but it's not the most useful definition that I've come across because it doesn't actually cut to the chase of what we do necessarily. People can't envisage it. And therefore, what people tend to envisage when they think about palliative care is this. And I know you're thinking it. Everybody thinks it. And even though you are in a completely different place to me and 3 weeks ahead of me, I can feel you thinking this through the screen because everybody, when you talk about palliative care, thinks death. And to be fair, palliative care has earned that reputation for itself, hasn't it? Because it is a specialism that has dealt with complex end of life care for people and therefore has become known for that and only that. But it is a specialty which does a lot more than that. And if you are offered a referral to palliative care, it's because it's been suggested that you might gain something from it that will help you to live better. So the focus from palliative care, from our perspective, is on quality of life. We want to make sure that your quality of life for however long you have is as good as it can be. Being referred to us does not mean you are dying. If you are dying and you end up having severe or complex symptoms that need treatment, of course we will look after you. Of course, we're the right people to look after you, but that isn't the extent of what we do. And actually, while some people are worried about a referral to palliative care meaning that they're dying, the research has shown that people that access palliative care earlier live longer. So it is not a testament to living a shorter amount of time by seeing a palliative care person. It's trying to keep you in a better condition with better quality of life for longer if we can. And one of the areas that I'm very focused on is supportive care in cancer in particular. So that's about managing treatment side effects and toxicities to try and keep people well on treatment, but also to try and help them adhere to their treatment. So things like radiotherapy and chemotherapy, if the side effects are so horrible that you can't continue with those treatments, then you stop having them and you end up becoming more unwell because you've not been able to have the treatment that was intended. If you're seeing a palliative care person, however, that's able to manage those symptoms and you can therefore carry on treatment, that's all to the good. We're not there to stop you from having treatment. We want to facilitate that if that is your goal. The other thing to say is that palliative care as a specialty is not just about cancer. And I think people who have cancer and work in cancer circles are quite surprised by this. So, about half of the work that palliative care as a specialty does is in chronic disease management. They're seeing patients with COPD, with heart failure, with chronic neurological conditions. It's not all about cancer end of life care. And therefore, our models and our structure of care is designed to support people with chronic diseases for as long as we can. And there's no reason why people with cancer can't access services on that basis in the same way that other people with chronic diseases access them. And there's a great quote from Catherine Mannix, who was a palliative care physician turned author. And she posts things on Twitter and social media. And one of the things that she said that I really liked is patients who see a palliative care team are not obliged to die. It is not an expectation from us that you only get referred to us if you are dying. We want to see you early. We want to keep you well. That is our goal. So if you're thinking about palliative care, but what comes to mind is this picture, you need to move away from that because that's not the way we're working anymore. But there are other misconceptions about palliative care as well. And this is the next one, that we're some kind of religious order. And I have to say, this has actually been a harder stereotype to shift than the Grim Reaper picture. The number of people that have confused me for a priest is significant. Even once, I did an entire ward round, introduced myself as the consultant. I assessed people, physically examined people, and prescribed medications, and still people mistook me for a priest. So, this is something which is pretty ingrained in palliative care. And don't know exactly why. I think part of the reason is if you look at the hospices. Now, hospices are great. They do a really good job, but look at the names of the hospices. In my local area, we've got St. Luke's, St. Rocco's, St. Kentigern's, the Hospice of the Good Shepherd. They're all great places, and I'd be happy to be cared for in any one of them. But they have a slightly Catholic school lilt to their names, don't they, with Saint this and Saint that. And that has created an idea that in order to get palliative care, you have to kind of be involved in the religious aspect to it. But actually, that is not true. I think part of what we do in terms of spiritual care can be confused for religious care, and that's not what it is. I am not a religious person. I don't deliver religious care, but I do deliver spiritual care. And the difference is the personalized elements to you that make you you and that are important to you that I need to respect as a clinician. So, for example, it might be that your religion is important to you, and therefore I need to be respectful of that and make sure that you have access to religious support if your health is deteriorating. Or it might be that you're very attached to your dogs, like I am, and if your health were to deteriorate, one of the important things to you would be to be surrounded by your dogs. Or it might be that your personal preferences for care are around preserving mobility or independence or staying in work or spending time with your children or whatever the goals are, whatever the elements of life are that make you you, those are your spiritual needs. And we talk a lot in palliative care about trying to provide spiritual support for people, but that's what we're talking about. We're not necessarily talking about religion. So don't look at palliative care as some kind of religious thing either. We're just trying to work out what makes you tick and how we keep you able to access the things that are important to you. This is the other thing we're known for. The fear, I think, is that we give everybody morphine and addict everybody to opioids. So in the space of one slide, I've gone from being a nun to Pablo Escobar. This is also false to some degree. Now, of course, no smoke without fire. We do use morphine, but we use morphine for pain. It's a good painkiller. And actually, one of the things that we have to do is control pain. It's our duty to control pain, and it's your right to expect that if you have pain, it will be managed. Now, morphine is for specific kinds of pain. Not every kind of pain responds to morphine. Not every kind of pain needs morphine. And we will not just dish out morphine to anybody for any reason. There is more calculation to it than that. But it's something that is part of the toolkit, I suppose, that we use. It does not mean that you are dying, though, if somebody like me offers you morphine. We use morphine early to get pain controlled early because the evidence is if you get pain under control and keep it under control from an early point, it's easier to keep it under control than delaying and delaying and delaying and letting pain escalate and escalate and escalate. Because then trying to claw it back under control is a lot harder. So we are proactive with our pain and symptom control. But you haven't got to just have pain to see a palliative care person. You could have any number of symptoms. You could have no symptoms at all, but have quite a lot of psychological needs. It doesn't matter to us. We will see you and we will do what we can to help you. But the idea that we give everybody morphine irrespective of what they need is simply not true. If we give it, it's because we're trying to manage pain specifically. So we've talked about the things that it's not. This is actually what I think it is. Now, I've borrowed this picture from one of the articles by David Hui, which I've referenced there, and I think this really speaks to what palliative care is. So what it is in the middle, trying to show you my cursor. I hope you can see that. In the middle, you've got the makeup of a patient's needs. So they've got physical needs, that might be pain or nausea. They've got emotional needs, social needs, spiritual needs, we've talked about, informational needs, all of the different things that somebody could need support with in terms of their care. Obviously, you've got the families surrounding the patient, and they have needs as well. And then surrounding those, the patient and the family, you've got all of these different healthcare professionals. No one professional deals with all of the needs that the patient has. They can't. No one person has all of the knowledge or all of the skill to be able to meet every single need that somebody has. But they're all working together. They're all coordinated together. So you've got a team of different people who, between them and their respective skill mixes, have representation that deals with the whole need for that person and their family. And this is what palliative care is. It's a team-based approach using lots of people's skills to deal with the holistic nature of people's needs when they're dealing with a chronic illness or an incurable illness, because actually the needs are broader than just painkillers. They are more emotional, social, financial. So there are people there in these teams to deal with that. And if you have complicated needs that you think, oh, I could just do with some palliative care to get a team approach on this, that's exactly what palliative care is about. So the next question is when? Well, the answer really is early. The evidence is if you need palliative care and you get it early, you get the benefits. And the earlier you get it, the bigger the benefits are. So early palliative care has been shown to prolong life. It improves mental health. That improves the likelihood of people having discussed wishes about their future care. It reduces chemotherapy use in the last 30 days of life. Now, I know that sounds a bit weird, but actually that's a good thing from our perspective, because what it means to us is that somebody has recognized that you are too unwell to carry on with chemotherapy and had a conversation and dealt with what your needs are without continuing to give chemotherapy without having a conversation about where we are. Improved quality of life, improved symptoms, spiritual well-being, patient satisfaction. The evidence is all out there that earlier is better, but with a caveat. Not everyone needs specialist palliative care. Now, there is a difference between specialist palliative care and generalist or primary palliative care. The people that you meet that are looking after you during your period of having a chronic or incurable illness, they are delivering primary palliative care to you. If your GP is giving you symptom control, if your GP is talking about your psychological needs, if you're discussing your wishes for the future with your GP, that's not specialist palliative care, but it is palliative care, and it's delivered by the person who knows you best. It's if those needs are more complicated than those first line clinicians can deal with, or if you need that team that's dedicated to your needs, is when you would receive specialist palliative care, which is that sort of picture I showed you before with the orbit. So yes, do it early, but don't expect necessarily to see a palliative care consultant if your needs are actually met by your GP or your oncologist or your district nurse, for example. Engage with it early so that you're getting all of the benefits without necessarily expecting to see a palliative care team, unless that's what you need. And of course, we want to see you if that's what you need. So what are the options? Well, there are a few options out there, and the difference between them actually largely rests with you and your choices and your ability to communicate them. So this is where your ability to advocate for yourselves and what you want really is important. So the first option is primary palliative care with nothing more complicated than that. So this is the, as I say, the palliative care provided by the people that you would see throughout your condition, your GP, your oncologist, your district nurse. These people are very well able to manage a lot of symptoms, have a lot of conversations, do a lot of planning with you about the future, and your care will be smoother if you engage in those conversations. Okay. And the reason I say that is there's a study that showed that there was a controlled trial. So they took half the patients in this trial and gave one half early palliative care, specialist palliative care. So they all saw a palliative care team, whether they needed it or not. And everybody else didn't necessarily see a palliative care team early. They got it if they needed it, but not if they didn't. But what they did get is they all had a thorough conversation with their GP about their advanced care planning wishes and what they wanted as their health deteriorated so that they could make the choices around where they were looked after, what kind of care they wanted, what was important to them from a primary palliative care perspective. And then when they looked at the different results and what those two groups got, they found that the people that had actually just had a conversation with their GP did better than the people that saw a palliative care team, whether they needed to or not, because actually it was the GP that was doing the day to day in terms of looking after those people in the community, making sure that their needs were met, making sure that if they wanted to be at home, that was respected and that was organized. Whereas the people that saw a specialist palliative care team without needing to didn't really get as much benefit from it. So actually, there was more to be gained by having the right conversation with the right person than accessing specialist palliative care, whether you needed to or not. So this is what when I talk about primary palliative care, this is what's important. If you want to have a conversation about the future and what you want and what your wishes are, your GP can have that conversation. And making sure that they know what your wishes are is, in many respects, more important than seeing a palliative care person to have that conversation, although we absolutely will if you need us to. Then you've got the option of hospital palliative care. So this tends to be if you've ended up in hospital unexpectedly or something's gone wrong and you're in hospital, which is, the reason why you would be in hospital. There are palliative care teams in hospitals that can help you and you can ask to see them. So if you've got difficult symptoms that aren't being adequately managed by the teams that you're seeing, if there's excess distress or you need additional information or support, these teams are there and they will be able to help you. Many of them, like mine, also run outpatient clinics. So if you've got ongoing symptoms and ongoing needs, you can see these people in clinic rather than being admitted to hospital. So you can access that. The barrier to that is a lot of people don't want to be in hospital. So, and when we talk about planning with your GP for the future and what you want, then one of the most common things that people say to me is, I don't want to be in hospital. And I don't blame them. You know, so actually, sometimes you won't see a hospital palliative care team because you'll have made the decision not to be in hospital. But if you're there, they are there too, so you can access them. Home. Home is an option. Some people, in fact, most people, want to die at home when the time comes and receive much of their care at home if they can along the way, if they're too unwell to come to clinic. Now, obviously, when I talk about that scenario, I'm talking about much later in somebody's illness to the point where we are thinking very much home-based care. But that's where most people tell me where they want to be. But that needs a plan because in terms of what's available to keep you at home and support you at home, you've got district nurses that can come once a day and if you call them, but with a delay. You've got community care packages, which at most come 4 times a day. And in between those care calls, if you need anything, if you need help with washing and dressing and eating and moving around, it's down to your family to do that. So this can't just happen. This needs a conversation with your family about who's willing to step up and support. It needs a conversation around what additional care is needed, what additional equipment might be needed. And telling people that your preference is to be at home and have that additional support before you get to the point where you really need it is important because actually it takes time to organize some of this stuff. The care package that I mentioned before, the 4 calls a day and a few night sits in the week, that can take a few weeks to materialize from the local authority. So people need to know that that's the plan before you get there. So again, this harks back to the importance of telling people, what do you want from an early point? You can be at home. It can help. It can be made to work and people can help you, but people can't move in with you. It's important that you know that. And you stand a better chance of being able to be at home if you tell people what you want from an earlier point. And then hospices. Now, everybody thinks hospices is where you go to die. And again, it comes back to that picture I showed you before of the Grim Reaper, because yes, it's got the reputation of that because it does do that, but it doesn't just do that. So many hospices now are for complex needs, complex symptom control, complex psychological support, for a period and then get people home again. So most people who go into a hospice go home again. They're there for a period of inpatient care, the same as you would go into a hospital for an inpatient care, but you wouldn't stay there, you go home again. So hospices are like that, but they're specific for needs that they cater to better than hospitals. So complex pain and symptom control, for example, a bit of rehabilitative support, a bit of psychological support, or a mixture of all of those things. That's when you would go into a hospice rather than a hospital. Some people will choose to die at their local hospice if dying at home can't work, and that's fine, except for the fact that hospices are sometimes full. So again, you need to be clear with your wishes before you get there that that's what you might want, so that people who are supporting you can direct you to, yes, that's a possibility, let's get you on the list, or actually the hospice is full, we need to look for an alternative, and here's that, and there are alternatives out there. Sometimes there are nursing homes that specialize in end of life care that are your alternative to a hospice. So there's different options in different regions, but the communicating early is important. You can also be referred to a hospice for outpatient care or well-being support. So if you need to see somebody in clinic, you don't need to be admitted, but you do need somebody to review your medications and give you something for symptoms, that can happen in a hospice clinic. If you don't need to see a doctor, but you need to do some physiotherapy or go to some classes on physiotherapy or occupational therapy, some anxiety management, some psychological support sessions, those can happen in the well-being services that most hospices run, where you go once a week for a period and build yourself up and get some support that way. So there's a lot going on in hospices that's not just inpatient beds where you go to die. It's more about keeping people well, keeping people out of hospital, providing an option for inpatient care for a period if people need it, but it's moving more away from you go in there and you don't come out, because actually that's not what the model is anymore. It's trying to get you better and get you home. And don't forget the third sector. So charities. So there's a lot out there designed to help people that is not NHS. So you think Maggie's, for example. You think Make Seconds Count. You think of the different charities that support people psychologically. So places like, I work in Liverpool, so I can give you a list in Liverpool, but if you're not in Liverpool, you won't know. But there's, Sunflowers and different Lindale centres, and there's also not Maggie's, Macmillan nationally. So there's lots of different people who do bits of this that you can access as well. So if you want to do an exercise class for somebody on chemotherapy, Maggie's is a good place to do that. If you want to learn more about nutrition, a lot of these charities have got that. If you want to access counselling, then Macmillan will provide you with some of that. So there are different options from different people that you can almost shop around. You haven't got to wait for NHS palliative care to give it to you. If you want it and you've got some options local to you to get additional support, that's absolutely fine. So what's the summary? So palliative care is here to help you live as well as possible despite a condition that can't be cured. It does include end of life care, I won't lie to you, but that's not the extent of it. And actually, more of what we do now is chronic disease management and keeping people well through treatment, and less inpatient end of life care. So don't be frightened of us. We're there to help you, and we're there to work towards your goals. It's part of that treating the whole person. If you tell us what your aims are, we will try and help you get to that and be supported in doing that. And if you get involved early, it will increase the likelihood of getting a better outcome. And if you've got wishes for the future that are quite specific, tell people early so that people know what the rules are before you get there. It makes a big difference to involve people in your planning for the future. And that can be, or should be, healthcare professionals, but also your family. We talked before about the fact that care packages in the community, they're 4 calls a day, they're not 24 hours. So you do need people to step in and help in those gaps between care. And those people need warning too. So part of your planning for the future and your palliative care needs also is a conversation with your family as well. So I'll leave you with that thought. I hope that's been useful in terms of busting some myths and all of that. But don't be frightened of us. Come and have a conversation with us. Come early, learn what we do, and tell us what you want. We're one of the few specialties where you can walk in and say, "I want this," and we will try very much to accommodate you. All right. So there's some references of some of the things I've been talking about if you want to check up on any of it. And take care. Nice talking to you.